You are doing everything right. You cut the salt. You take your medication every morning without fail. You walk. You eat vegetables. You gave up processed food months ago. And yet, every time you sit down in that chair at your doctor's office and they wrap that cuff around your arm, the numbers come back higher than they should be. 160 over 95. Maybe 155 over 90 on a good day. And your doctor looks at the screen, adjusts your prescription, and sends you home with the same advice you have been hearing for years. Less salt, more exercise, come back in 3 months. But here is what nobody is telling you. For a significant number of adults over 60, blood pressure does not stay elevated because of what you are eating. It stays elevated because of a hormonal system running quietly in the background, one that was never designed to operate the way modern life forces it to, and one that no amount of salt restriction will fix. I am Dr. Richard Hale, and after years in clinical practice, what I find most troubling is not the patients who ignore their health. It is the patients who do everything right and still cannot get their numbers down, because those people deserve a real explanation. In the next 20 minutes, I am going to walk you through exactly why blood pressure becomes so resistant after 60, what is actually driving it in most cases, and what the research now tells us about addressing the root cause rather than just chasing the number. Stay with me, because what I am about to explain will completely change how you think about this. Let us start with something fundamental that most blood pressure conversations skip entirely. Blood pressure is not one problem. It is the end result of 3 separate systems all working at the same time. The first is cardiac output, which is simply how much blood your heart pushes out with each beat. The second is blood volume, which is the total amount of fluid circulating through your body at any given moment. The third is vascular resistance, which is how relaxed or constricted your arteries are. If any one of those 3 goes up, your pressure rises. If 2 or 3 go up together, your pressure can become very difficult to control. Now here is why this matters so much for people over 60. The conventional advice, eat less salt, targets only one of those 3 systems. Specifically, it targets blood volume. The logic is straightforward. Sodium pulls water into the bloodstream. More water means more volume. More volume means higher pressure. Reduce the sodium and the volume drops and the pressure follows. And for some people, that works. But research consistently shows that roughly half of people with high blood pressure are what we call salt insensitive, meaning their pressure does not meaningfully respond to sodium reduction. They can cut salt dramatically and see almost no change in their numbers. The reason this happens is that for those people, blood pressure is not primarily being driven by volume. It is being driven by something else entirely, and that something else is almost never discussed in a standard 10-minute appointment. Before I go further, I want to take a moment here. If you are finding this useful, if you feel like you are finally getting a real explanation rather than the same generic advice repeated back to you, please consider subscribing to this channel. My goal is to bring you the kind of clear, evidence-based information that helps you understand what is actually happening in your body, not just what to do about it. Hit the subscribe button. It takes 2 seconds, and it means these videos reach more people who need them. Now, let us talk about what is actually driving blood pressure in a significant proportion of older adults whose numbers will not respond to standard treatment. The answer comes down to a hormone you have almost certainly heard of, but probably not in this context: insulin. Now, before you switch off because you think this is a conversation about diabetes, stay with me. Because insulin does not just regulate blood sugar. It is one of the most powerful pressure-regulating hormones in the entire body, and almost nobody talks about this. When you eat, particularly when you eat carbohydrates, your blood glucose rises, and your pancreas releases insulin to move that glucose into your cells. That part most people know. What most people do not know is that insulin simultaneously sends a direct signal to your kidneys telling them to hold on to sodium. Not because you ate salt, but because insulin itself is a sodium-retaining hormone. Researchers have demonstrated that insulin directly stimulates sodium reabsorption in the kidneys, independent of how much dietary sodium a person consumes. Read that again. Your kidneys can be retaining sodium even if you have not touched a salt shaker in months, simply because your insulin levels are telling them to. In a healthy metabolic state, this is not a problem. Insulin rises after a meal, does its job, and falls back to baseline within a few hours. The kidneys hold a little sodium temporarily and then release it once the signal clears. The system resets and pressure stays stable. But here is where aging changes everything. After 60, a significant proportion of adults develop some degree of insulin resistance. This is not the same as diabetes. Insulin resistance means your cells have become less responsive to insulin, so your pancreas has to produce more of it to achieve the same effect on blood sugar. You might have perfectly normal blood sugar on a standard test and still have chronically elevated insulin levels running in the background throughout the day. Research published in the Journal of Clinical Endocrinology and Metabolism has found that insulin resistance affects an estimated 40% of adults over 60, and many of them have no idea because their fasting glucose looks completely normal. When insulin is chronically elevated, the signal to the kidneys never turns off. They stay locked in sodium retention mode regardless of what you eat. This is why so many older adults reduce their salt intake to almost nothing and see virtually no change in their blood pressure. The dietary sodium is not the issue. The hormonal instruction to retain it is. And cutting the source does not help if the signal telling the body to hold on to it is still running at full volume. This is what I mean when I say that for many people over 60, blood pressure management is not fundamentally a dietary sodium problem. It is a hormonal signaling problem. And treating it as though it were purely a sodium problem is why so many people end up frustrated, medicated, and still hypertensive despite doing everything they were told. Now let us add the second layer, because insulin is only part of the story. The other major driver of resistant hypertension in older adults is something called endothelial dysfunction. Your endothelium is the thin layer of cells that lines the inside of every blood vessel in your body. In a healthy state, these cells produce a molecule called nitric oxide, which acts like a natural relaxant for your arteries. When nitric oxide is abundant, your blood vessels stay flexible and open. When it drops, your vessels stiffen and narrow, and vascular resistance, that third component of blood pressure, climbs. Research published in the Journal of the American College of Cardiology has shown that endothelial nitric oxide production declines significantly with age, and that this decline accelerates in the presence of insulin resistance, chronic inflammation, and metabolic dysfunction. What this means in practical terms is that many older adults are dealing with two simultaneous pressure drivers. Their kidneys are hormonally locked into sodium retention mode, which keeps blood volume elevated, and their arteries are stiffer and less able to relax, which keeps vascular resistance elevated. Both arms of the blood pressure equation are being pushed up at the same time. And a standard prescription targeting only one of those mechanisms, which is what most blood pressure medications do, is always going to be fighting an uphill battle against a system that is working against it from multiple directions at once. Now let us talk about something that I think gets overlooked almost entirely in standard blood pressure management conversations. Insulin does not just affect the kidneys directly. It also activates the sympathetic nervous system, which is essentially your body's emergency response system. When the sympathetic nervous system is activated, your heart rate increases, your blood vessels constrict, and your cardiac output, that first component of blood pressure, goes up. In a healthy person who eats a meal and then goes without food for several hours, the sympathetic nervous system gets a chance to downregulate once insulin falls. The body settles, the heart rate comes down, the vessels relax. But when insulin is chronically elevated, because eating occasions are spread across 12, 14, or even 16 hours of the day, the sympathetic nervous system never fully stands down. It stays in a state of low-grade activation throughout the day and into the night. What this means for blood pressure is that all three of the components we discussed at the start of this video, cardiac output, blood volume, and vascular resistance, are being simultaneously pushed upward by the same underlying hormonal driver. The heart is beating slightly harder and faster than it should be at baseline, the kidneys are holding on to more sodium than they should be, and the blood vessels are slightly more constricted than they would be in a properly regulated hormonal environment. None of these effects are dramatic in isolation, but together they produce blood pressure that sits persistently above where it should be. And because none of them are directly related to how much salt you are eating, cutting sodium does not meaningfully address any of them. Here is something I want you to think about carefully, because this is where clinical medicine often falls short. Most blood pressure medications are genuinely effective at what they are designed to do. An ACE inhibitor reduces the hormonal signaling that constricts blood vessels. A diuretic forces the kidneys to excrete more sodium and water. A calcium channel blocker relaxes arterial smooth muscle directly. These medications work. They save lives. I am not suggesting otherwise. But what they do not do is address why the pressure was high in the first place. They manage the downstream consequence without touching the upstream cause. And what the research consistently shows is that when the underlying metabolic drivers are improving, medications work better. People who are addressing insulin resistance, reducing chronic inflammation, and improving endothelial function through lifestyle changes often find that they achieve better pressure control with the same or lower doses. In some cases, and always under the supervision of a doctor, they are able to reduce their medication load over time. The medications and the lifestyle work together. Neither replaces the other. But if you are only doing the medication side of that equation, you are asking a very powerful drug to compensate for a system that is still fundamentally pushing in the wrong direction. So what does addressing the root cause actually look like in practice? Let me walk you through the specific mechanisms that research supports for improving insulin sensitivity and endothelial function in older adults. The first and most consistently supported intervention is time-restricted eating. A study published in Cell Metabolism found that restricting food intake to a 10-hour window without changing what people ate or how much they ate resulted in meaningful reductions in blood pressure, improvements in insulin sensitivity, and better metabolic markers across the board. The mechanism is straightforward. When you go for extended periods without eating, insulin drops to genuine baseline levels. When insulin is low, the kidneys receive the signal to release sodium naturally. Blood volume normalizes, and the sympathetic nervous system gets a chance to downregulate. You do not need to fast for days. You do not need to follow an extreme dietary protocol. What the research suggests is simply that creating a consistent window of time each day where you are not consuming anything that triggers insulin gives your pressure-regulating system the opportunity to reset that it would otherwise never get. For many people, that means finishing dinner earlier in the evening and not eating again until mid-morning the following day. The exact structure matters less than the principle, which is giving your hormonal system a genuine break long enough for insulin to fall back to true baseline. The second mechanism is resistance exercise. Most people think of exercise for blood pressure in terms of cardiovascular activity, and aerobic exercise does genuinely help through its effect on nitric oxide production. But resistance training offers something additional and specific. It improves insulin sensitivity in muscle tissue directly. Research published in the Journal of Applied Physiology has shown that moderate resistance exercise can improve insulin sensitivity for an extended period afterward. More insulin-sensitive muscles mean less insulin required to manage blood sugar, which means lower baseline insulin levels throughout the day, which means less hormonal pressure on the kidneys to retain sodium and less activation of the sympathetic nervous system. For older adults, resistance training also preserves muscle mass, which is itself one of the most important factors in long-term metabolic health and insulin sensitivity. Even light resistance work, body weight exercises, resistance bands, or light weights done consistently can make a meaningful difference to the hormonal environment that controls blood pressure. The third mechanism is dietary nitrates from whole food sources. Leafy green vegetables, particularly those higher in natural nitrates, provide the raw material your body uses to produce nitric oxide through a pathway that remains functional even when endothelial nitric oxide production has declined with age. Research has found that dietary nitrates from vegetable sources can support vascular function and contribute to blood pressure regulation in older adults. This is not about any single superfood or special supplement. It is about consistently including vegetables in your diet so that your body has the substrate it needs to support arterial relaxation even when the endothelium is not producing nitric oxide as efficiently as it once did. The fourth mechanism, and this one is consistently underestimated, is sleep quality. Studies have found that poor sleep quality is independently associated with elevated blood pressure, increased insulin resistance, and worse cardiovascular outcomes. During deep sleep, your sympathetic nervous system downregulates, your cortisol drops to its lowest point, and your body performs the hormonal recalibration that keeps your pressure-regulating systems functioning properly the next day. Sleep deprivation, even partial sleep deprivation over several nights, has been shown in research to meaningfully reduce insulin sensitivity in adults. If you are managing blood pressure without addressing sleep, you are leaving one of the most powerful levers completely untouched. And for older adults who often experience changes in sleep architecture and sleep quality, this is particularly relevant. Let me bring this back to the clinical picture because I think it is important to ground all of this in something concrete. The people who struggle most with resistant hypertension after 60 are often not the ones making obvious unhealthy choices. They are frequently the ones who have followed conventional advice carefully and found it insufficient. They have cut the salt. They are taking their medications. They are doing moderate exercise. And the numbers still will not move to where anyone wants them to be. What the research increasingly suggests is that for this group, the missing piece is almost always metabolic. Specifically, it is chronic low-grade insulin elevation that the body has adapted to over years or decades, combined with the natural decline in endothelial function that comes with aging, and the persistent low-level sympathetic activation that results from both. Addressing those drivers does not replace medication. It does not mean ignoring dietary sodium, because sodium still matters. It means adding a layer of intervention that targets the actual hormonal machinery driving the pressure up in the first place. And when that layer is added, what the research shows is that the rest of the treatment strategy tends to work better. The medication becomes more effective, the sodium restriction has more impact. The exercise produces more measurable benefit. Because you are finally working on the system that controls pressure, not just the downstream numbers that system is producing. I also want to be direct about something important here. Everything I have discussed today is about understanding mechanisms and working alongside your doctor, not replacing that relationship. If you are on blood pressure medication, do not change your dose or stop taking it based on anything you hear in this or any other video. What I am giving you is the framework to have a more informed conversation with your healthcare provider about the metabolic factors that may be contributing to your readings. That conversation is worth having, and you are now better equipped to have it. Here is what I want you to take away from everything we have covered today. Blood pressure after 60 is not a simple problem, and it does not respond to simple solutions for everyone. If your numbers are not responding the way you expected to the standard advice, that does not mean you have failed. It may mean that the advice has not addressed the right mechanism for your physiology. For a significant proportion of older adults, the primary driver of persistent hypertension involves insulin signaling, endothelial function, and sympathetic nervous system activation, not purely dietary sodium. Understanding that distinction changes how you approach the problem. It shifts the goal from chasing a number to restoring the biological conditions that allow your pressure-regulating systems to function the way they were designed to. That means looking at when you eat, not just what you eat. It means incorporating resistance exercise alongside cardiovascular activity. It means treating sleep as a medical priority rather than an optional recovery activity. And it means having a conversation with your doctor that goes beyond the prescription to the underlying metabolic drivers that the prescription is trying to compensate for. None of this is complicated once you understand the why behind it. And understanding the why is exactly what I am here to help you with. If this video gave you a clearer picture of what might be driving your blood pressure, please subscribe to this channel. Share this with someone over 60 who has been struggling with the same frustration. And leave a comment below telling me whether you have ever been told about the insulin connection to blood pressure, because in my experience, most people have not. I will see you in the next one.